show you this one, Pete. Well, good afternoon, ladies and gentlemen, and a warm welcome to our speaker, Professor Phil Steer, Professor Emeritus of Imperial College and the past editor of the British Journal of Obstetrics and Gynecology, which we call BJOG nowadays. It's wonderful to have Professor Steer speaking to us. He is speaking, are you in London at the moment, Phil?
I am indeed.
Okay, wonderful. And the topic is the significance of meconium and pyrexia in labor for neonatal outcome. As you all know, Professor Phil Steer is the chief editor-in-chief of that Bible of Obstetrics, and he is now, as we speak, working, is it the 6th edition that you're busy revising?
Yes, 6th edition, yeah. Yeah, with
Absolutely.
Cambridge University Press.
That's wonderful, and we're looking forward to having that edition out. I hope it doesn't take too long, because it's our Bible and we rely on something of that importance in our day-to-day obstetrical practice. It's a beautiful day here where we?
No, we are.
No, we're in Cape Town, Steve, and with me I have Professor Steve Jeffrey, and he is the co-chair this evening. The sponsor this evening is the Pelvic Floor Foundation of South Africa. We'd like to thank them very much indeed for sponsoring this Zoom and webinar on this occasion. Professor Phil Steer, we're not going to waste your time, and it's great to have you speaking about the significance of meconium and pyrexia in labor for neonatal outcome. Professor Phil Steer.
Thank you, Peter, and also Stephen, for giving me this opportunity to speak to your group for the 3rd time. And I was looking at the first one I did, which was actually about the ABC project, joint between the RCOG and the THIS Institute in Cambridge, which was avoiding brain injury in childbirth. So I thought I'd start. I'm just going to share my screen. So you should be seeing my slides now. Yep.
Yes, we can see them.
We have them here.
Yeah, good. So I thought I'd start just by giving you the good news that this paper, I talked to you about the project which was in progress at the time, has now come to fruition, and the paper appeared in February in BJOG. And in that paper, we were looking at a whole range of features which contribute to the neonatal outcome, not just the fetal heart rate. And this is the emphasis, which is looking at other factors during labor which influence that outcome. So this is just a very quick revision of what we found during that study. So we compared the outcome in the infant trial, which is 69 adverse outcomes, babies that died, ended up with brain injury, out of 46,000 women in the infant trial, compared with a local audit in and around London of 160 babies with a normal outcome. This was in 4 separate units, so about 40 in each unit, where fetal heart rate monitoring was used. And to cut a long story short, you'll see that the odds ratio of an adverse outcome, that's in the infant group, was very much higher if you had fetal growth restriction. But looking at the intrapartum variables, they're here. You can see there's a heart rate abnormality, meconium, and tachysystole, that's excessively frequent contractions. So we've talked endlessly in the past about changes in the heart rate. So I'm going to talk initially about a few aspects of meconium. Now, just to remind you how we did this particular study, it was looking at these different risk factors. So growth restriction, meconium, pyrexia, and that's the other topic for today, bleeding, tachysystole, compared with the heart rate changes. And if you put a 1 in each of these boxes, you added it up to a score. And again, just to summarize, if you looked at the total score that was reached during each labor, you can see a clear cutoff. This is in the normal outcome group. Only 17% ever reached a score of more than 10 in total, compared with more than 2/3 in the group with the adverse outcome. So that we are within a reasonable distance of being able to develop a way of predicting the outcome of labor as labor carries on. And in fact, if you did receiver operator curve characteristic, you can see that the area under the curve was 0.85, which is pretty good. Anything more than 0.7 is regarded as a relatively good prediction. So that's the summary of what I talked to you about 2 years ago. Now, this paper has just been accepted, and I've literally just had the proofs yesterday. And this is a study not of a few hundred women or even 46,000, but actually 1/3 from a data set that we collected in the North Thames region over a period of 13 years from 1988 to 2000. And what we were looking at in this particular analysis was the odds ratio of the baby having a low 5-minute APGAR score, 5 minutes being more significant than the 1-minute APGAR score. And you can see the usually expected things like growth restriction, induction of labor, being nulliparous, obese, etc. But I'm going to concentrate for today on these factors down here, because we've got oxytocin, we knew about that. We've got pyrexia, which was an important predictor. And I'm going to, the second half will be on this. But what we've done here, which is different at the bottom, is we've looked at an abnormal CTG with clear liquor, and then meconium with a normal CTG. That's without CTG abnormality. It's a slightly odd way of putting it, but that's the statisticians for you. Fairly similar. But the key thing here was that the combination was about twice as bad as either alone. So for the first time, we can start to put numbers. We all know it's probably not a good combination, but how much worse is it when you've got both? And the answer is, in this particular study, about twice as bad. This is looking at the low APGAR score. Now, if we look at the low APGAR score plus the need for intubation at delivery and resuscitation, plus babies that died, not many, but obviously very important, then we see that that trend is exaggerated. So just the abnormal CTG, sorry, that's pyrexia, abnormal CTG on its own without meconium. Now you see a big jump with the meconium on its own. And that's because, of course, a lot of those babies end up needing intubation because they've got fit meconium. And then the odds ratio here for when you've got both. So when you've just got an abnormal CTG, you're about 3 times more likely to end up in this group. But if you've got meconium as well as an abnormal CTG, you're 15 times more likely. So we can see it's a particularly bad combination. So a quick revision about what we know about meconium. It's the contents of the fetal bowel. And we know from clinical experience day to day that some babies pass this into the amniotic fluid during labor. This is just a little bit of physiological background. In order to pass meconium, or in order to go to the loo when you're an adult for that matter, you need the appropriate neural network in your bowel to produce peristalsis. And you need a local hormone being produced in the wall of the bowel called motilin. And when you've got both of these at the same time, you get peristalsis. And that needs to mature as the baby gets older, because obviously once the baby's born, it has to be able to poo. Now that is not necessary earlier in pregnancy. So you'll see how this develops as pregnancy progresses. Now, we all know from practical experience that if you're suddenly exposed to a severe stress, suddenly you find that you've gone to the wrong boarding gate for your aeroplane, for example. You suddenly get this urge to have your bowels open, or if somebody's coming at you with a gun, you might have the same response. So how does this play out actually in labor? Because that's a pretty stressful thing for babies, because it's a hypoxic stress having to go through labor. So what we see here is that up to term, up to 37 weeks, the incidence is running somewhere around about 5 to 7%. So it's not particularly common. But once the baby starts to mature, the incidence goes up and up and up. And by this stage, we're getting up to about 30 to 40% once you get beyond 42 weeks. So it becomes increasingly common as the bowel matures. Now, something you may not immediately notice, and that is this green line. What I've done here is separate the incidence of meconium by the different racial groups. And what we see here, that's just the cutoff showing the rise after term, is that the Black Africans actually have a much higher rate than the white European group are down here at the bottom. So we looked at this in more detail, and in fact published this quite a long time ago now, more than a decade ago, in the Green Journal, very appropriate for a paper on meconium. And what you can see here is that we've analyzed it. These are the white European group. This is the South Asian group, which are more nearly a little bit more, but not dramatically more. But you can see here there's really quite a statistically and clinically significant difference. In other words, about 13–14% of white Europeans will pass meconium once they get to this stage of pregnancy, but it's actually nearer 25% if you have Black African heritage. Now, we think that this is physiological and may well be genetic, but that remains to be seen. And it's obviously relevant in your local practice that this is something that you'll see rather more often than we would in London in the white population, for example. Now, coming back to this point about stress causing the baby to pass meconium, this is a study that we did a long time ago, a quarter of a century ago, when we developed a special probe which looked at the color of the amniotic fluid, which you could pass up past the baby's head. And when it went green, we knew there was meconium. We could actually measure it in grams per liter. So this is a normal level of meconium. This is quite common, around 20 grams per liter. You wouldn't notice this clinically. And what happened here was that this baby got a bit stressed, mother got a bit hot, she got a bit hypotensive, and the fetal heart rate went up. You can see the tachycardia here. And as a result, this baby passed meconium. And it came out in a splurge. There was a sudden splurge. So it doesn't trickle out. It's like, explosive diarrhea, really, a sudden splurge. And then here, there's another big splurge of meconium. And this is getting up to be quite thick meconium. And then gradually it dissipates and spreads out. And so the concentration starts to fall again. So we can see the relationship of stress to passing meconium. And this is illustrated in this slide, again from the Northwest Thames data set. If we have labours where the fetal heart rate remains normal throughout labour, you can see, as expected, the incidence of meconium is around about 3, 4, 5% going up at term. But at all gestations, if the heart rate becomes abnormal, the baby is then more likely to pass meconium. And you can see it almost doubles the incidence. So another reason to get concerned, because when you've got a normal heart rate, your incidence of passing meconium is going to be minimal. But you can double it if you overstretch. Supposing you hyperstimulate, the baby gets an abnormal CTG, it's then more likely to pass meconium. So you've got a double whammy, if you like. Now, this again is looking at the APGAR score at 1 minute. And if we can, instead of just looking at the APGAR score less than 7, this particular slide looks at each individual APGAR score as a group. And what you can see is that when the CTG is normal and there's no meconium, we have the best possible outcome, the lowest incidence of low APGARs. And then with meconium alone or abnormal CTG alone, they're fairly similar in significance. But as soon as you have both, you go up again. So you pretty much double the risk again if the CTG is abnormal and there is meconium. Now, this is the 5-minute APGAR score, which basically tells us much the same thing. In this situation, the CTG abnormality is slightly more important than meconium alone, but the combination is what really does the damage. Now, this is a paper that we published a long time ago. It's only 1,000. We're not talking about 1/3 here. This is only 1,000 cases that we published. But what I was looking at here was the interaction of heart rate changes with meconium and whether the baby was acidotic when it was born. So these were the pHs of the baby at birth. This is on about 1,000 babies. So you can see that when there's meconium, but the heart rate is normal, there's no significant change in the pH of the baby in the cord gases. If the heart rate becomes abnormal, then the pH tends to be lower. We're all expecting that. That's what we understand by the concept of fetal distress. But what you see here is that if you then add meconium, it goes lower again. So we've got the situation where the meconium on its own with a normal heart tracing is relatively innocuous. But if you then allow the baby to develop an abnormal heart rate pattern, suddenly you get an additional risk element being introduced. Now, you'd expect, of course, there to be a relationship with intubation, because babies that have a lot of meconium around often get intubated. So let's just look at the rate of intubation. And this is, again, in nearly 500,000 cases again here we're looking at. If the CTG is normal and there's no meconium, then few babies get intubated. If there's meconium, a lot of them get intubated, as you'd expect. So that's about 6%. Abnormal CTG pushes up the intubation rate, as you'd expect, but not as high as this. But again, it's the combination that does the worst damage. So it's important to avoid, to watch particularly closely the CTG if there's meconium. And if the CTG becomes abnormal, you need to be twice as worried as you would be if it was just that the CTG was abnormal. What about intrapartum stillbirth? Very low rate, of course, when both were normal. Meconium alone is associated with some increase, a significant increase, but the abnormal CTG is most associated. But yet again, we see an almost doubling of the stillbirth rate if you have both. So is this just our finding? Well, other people have looked at this as well. Here's a paper from about 9 years ago, looking at intermediate heart rate abnormalities, not the grossly abnormal ones, but the ones that are often difficult to categorize. What happens if you have meconium as well? And they looked at just over 3,000 women who had these intermediate abnormal heart rate traces, and about 1 in 5 of them had meconium as well. And what they found was that compared with the ones where there was no meconium, the babies with meconium, as well as these intermediate tracings, were 2.5 times more likely to have all these problems, neonatal death, morbidity, etc., etc. So again, confirming that you approximately double, perhaps even a bit more, the abnormal outcome if you add meconium to the abnormal CTG. So this is the interaction. So what can we conclude about meconium? Well, primarily, the main reason that meconium is passed is that the baby's getting more mature, and babies have to learn how to poop, otherwise they don't survive very well when they're born. It does not increase the risk of acidosis if you just have meconium, provided the FRHR pattern is normal. However, as soon as you get the combination, it's bad news. The biggest risk by far is a combination of the two. So how can we use this in clinical practice? If there's a normal heart rate pattern, you just observe. You don't need to do fetal blood sampling. You don't need to get particularly worried. You just monitor the heart rate pattern. If it's just an abnormal heart rate pattern, then in our practice, some of us might still consider doing a fetal blood sample if that's the only abnormality. But if there's an meconium and an abnormal heart rate pattern, then in my view, that combination, without worrying about pHs and other factors, is sufficient that you should be considering delivering the baby, because the outcome is likely to be relatively poor. Okay, so moving on to the second half, what I think is a greatly undervalued measurement and not taken as seriously as it should be in all cases is pyrexia. Now, this is going back a seriously long time. We're going back here 35 years or so, but it's one of the papers that I've been an author on that's been most highly cited. Nearly 200 times this paper's been cited. And what we were the first people in the world actually to publish papers showing that if you gave an epidural to a woman, her temperature was likely to start increasing. So this is women just given opiates, and there's women given an epidural, and you can see there's a rise of about 1 degree Celsius every 8 hours. Now, as the baby hots up, it gets a tachycardia, just like we do. So if you heat us up, we'll get a tachycardia as well. So this explains the fact that when you get a pyrexia, you often get a fetal tachycardia, and that becomes recognized as an abnormal heart rate pattern. Now, here's another factor that you may not have been aware of, but has actually been known a long time. Let's look at when this was. This is actually going back to 1903. So we're talking about 120 years ago. And what they actually did in this study was they looked at babies that were presenting by the breech in particular. 2 of the cases were breech presentation, and putting a thermometer into the baby, in this case, into the baby's anus. Now, actually, when they took the baby's temperature when it was presenting cephalically, they found about 1.6 degrees Fahrenheit, which is about, an average variation, 0.6, which is about 0.6 of a degree. But in the cases where it was breech and they were able to take the rectal thermometer, they found that the difference was actually 1.4 and 1.6, respectively, degrees Fahrenheit. That's about 1 degree difference. So that's really rather a clever study to have done all that time ago. And it was repeated again in the 1960s. So in 1964 by Carl Wood, Australian, and Richard Beard, who was my mentor. Again, in the British Journal, luckily. Now, what they were able to do was look at the fetal temperature in 8 patients. So the mean rectal temperature, these were all breeches. The mean rectal temperature was 37.6. The mean intrauterine temperature was 37.2, and the mean maternal temperature was 36.7. So a difference of 0.9 degrees. What this means is, of course, that if the mother's temperature is 37.3, the baby's temperature is going to be 38.2. And we would regard that as being a pyrexia, of course. And people forget that the baby is hotter than the mother. Why is this? Well, it's to do with the second law of thermodynamics. Heat can only pass from a hot body to a cooler body. You can pump heat from a cool body to a hot body, but that takes energy, an external heat engine, like a heat pump. If you haven't got a heat pump, hot bodies always cool down to the level of their environment eventually. So the fetal temperature has to be warmer than the mother so the baby can get rid of its heat of metabolism. This is mainly through the placenta. The difference in the temperatures above maternal core is about 0.5 degree in the amniotic fluid and about 0.9 of a degree in the baby itself. The placenta itself is the main area for heat loss. It's like a sort of radiator that manages to get rid of most of the baby's heat. We need to bear this in mind. Now, again, back in the 90s, I worked with a number of research fellows and we developed an intrauterine probe, which was separated by heat insulator here. And we had a little probe that measured the baby's skin temperature and the lower uterine segment temperature. And we were able to find a difference of about 1/4 degree. And this is one of the early papers that we published. And this was illustrating the fact that if the mother has an epidural, the fetal skin temperature was going up much higher than if the mother didn't have an epidural. And you can see some of these babies, in fact, there were 3 babies where the skin temperature was above 39 degrees Celsius. So that's really quite hot. This is a more recent, so we're only going back about 20 years now. When Charlotte Patient was my research fellow, and we were looking to see if we could see any effect of infection on the fetal maternal temperature difference, and we didn't actually. That's another story. But what you can see here is that the mother and the baby are maintaining thermal homeostasis until the mother has an epidural. And once she has an epidural, the temperature starts going up, and as I said, it's about 1 degree every 8 hours on average. So you wouldn't notice it initially, but by here, the fetal temperature is now up to 38.4. Now you may think, what's happening here? Well, this is where the first epidural dose was given. And then the temperature goes up and then it starts to go down again. Why is that? Because the epidural is wearing off. And the mother feels the pain again. So what does she do? She says, please top up the epidural. And when you top up the epidural, the temperature starts to go up again. So this baby is not so hot as some. The mother is relatively cool to start with, so this baby's only gone up to 37.9. Now, we then looked at, again, this is the Northwest Thames data, so again, we're looking at almost 500,000 babies. So in these babies here, we know it's related to the duration of labor. So if the mother doesn't have an epidural, the maximum proportion of the mothers who develop a pyrexia in labor is around about 2%. Even after a long labor. But you can see that with the duration of labor, if you have an epidural, the mother's ability to keep her temperature down is impaired. So there's a steady increase in temperature. And so you can see here that in this study, we're around about 9% of the women with an epidural are recognized as being pyrexial. That's greater than 37.5 on 2 occasions at the end of labor. Now, I'm going to start bringing in, this is where it starts, I'm afraid, to get a bit complicated, but this is where artificial intelligence may help us in the future, because it does get a bit complicated. So what we're looking at here is interactions. We're looking now with the interaction of the epidural and the pyrexia in the instance of abnormal heart rate pattern. So if there's no epidural and no pyrexia, we know that about 1/3 of babies will have an abnormal heart rate at some point during labor. If there's pyrexia, that goes up to over 50%. These are in women without an epidural. If you have an epidural, but you don't become pyrexial, this is women usually who've only had an epidural for a short length of time, then there's no increase in the instance of abnormal heart rate pattern. But if you have an epidural and pyrexia, then obviously it goes up again. So it's the pyrexia that gives you the abnormal heart rate and the tachycardia. It's not the epidural per se. It's the pyrexia that it produces. What about transfer to special care? Again, no epidural, no pyrexia, epidural, no pyrexia, relatively low rates of transfer. It's a little bit higher with the epidural cases. But what really makes the difference is the pyrexia. And in this case, there was a significantly higher rate of admission to NICU when there was a pyrexia without an epidural, presumably because more of these represent a real infection rather than just being due to the epidural. And now another interaction. I'm really keen on these interactions because this is what we have to sort out clinically. This is the duration of labor again. Here we've got women who never became pyrexial, and this is the incidence of meconium, which goes up as the labor progresses. So the more stress is on the baby, the longer the baby is stressed, the more likely it is to pass meconium. But if the mother becomes pyrexial, that increases the stress further, and a higher proportion of babies will then pass meconium. So you can see that all these variables are interacting with one another and tending to make each other worse. So here we're getting even more complicated. And so this is as bad as it gets. And after this, I'll try and make it simpler. Let's look at the group with no pyrexia and no meconium. Is the heart rate normal? So this is the best possible group. And sure, the incidence of low 5-minute APGAR score is not bad. So the mean APGAR score here is about 9.56. If the CTG becomes abnormal, but still no pyrexia or meconium, then that brings it down, highly significant. You see these confidence intervals are very tight. Now we've got pyrexia, but no meconium, and a normal CTG. The pyrexia itself will bring down the APGAR score, but if then you add the abnormal CTG, it brings it down significantly further. Now, meconium on its own, with no pyrexia, with a normal CTG, it has a bit of an effect, but as you can see, it's not nearly as bad as the other combinations. So meconium on its own, as we've said before, not too serious. But if you then add the abnormal CTG, as we've come to expect, you will exaggerate that difference quite markedly. Now we've got the worst group, pyrexia and meconium. If the CTG is normal, well, you're not doing too badly. But look what happens here. If you then develop an abnormal CTG on the background of pyrexia and meconium, then that's the worst possible outcome, and you have the highest instance of really low APGAR scores. So that shows you that they all interact with one another, and they're all additive. Intubation tells us a pretty similar story, actually. You'd expect this is pyrexia but no meconium, and this is meconium but no pyrexia, but the combination is the worst. Transfer to special care. No pyrexia, no meconium, normal CTG, abnormal CTG, so that bumps it up a bit. Pyrexia, a lot of babies will get transferred because they get to be observed. Just for meconium, they get dealt with in the labor room, they get sucked out, the baby's doing fine, goes to the ward in many cases, particularly if the CTG has remained normal. But if you've got the combination, then you're back to here again. So it's in this situation, the pyrexia is a particularly bad idea. Bad news for the baby. So how important is this pyrexia? This paper comes from a long time ago, but it's a very, very important paper from the Northwest Australia study, Karen Nelson and Judith Greether. And what they found was that if the mother had a fever in labor, they followed all these babies up. Because Northwest Australia is a relatively contained community, they can follow them up very well. And they found that the 9-fold increase in the incidence of unexplained cerebral palsy if the mother became pyrexial in labor, which is a worry, obviously. What about encephalopathy? Okay, the Western Australian case control study again here, Fiona Stanley. Maternal pyrexia, about 4 times more likely to end up with newborn encephalopathy. Now, Greenwell et al. Established that there was a link between the level of temperature increase and the adverse outcome. So babies got floppy as the mother got increasingly hot. Hypotonia here, greater than 15 minutes. They needed more assisted ventilation. And particularly here, worrying, the incidence of seizures was particularly high if the temperature went above 101 degrees Fahrenheit. So this shows a dose response to the level of temperature. So the higher the temperature, the worse it is for the baby. This is a paper from Oxford. And the combination of maternal fever with cord acidosis, bad news. So what you don't want to do is let the baby become acidotic, because when you have both of them, the risk is 12.5%. Now, I'd like to bring your attention to a paper that was published just in the last 18 months by a colleague of mine, anaesthetist Christopher Mullington. I think it's an excellent paper, and he looked specifically at whether intrapartum hypothermia was associated with neonatal brain injury. And he came to the conclusion that hypothermia in labor of any cause, whether it's due to epidurals or infection, is associated with neonatal brain injury. And further work is required to establish if epidural hypothermia is as bad as infection, or is it just the effect of the temperature alone. Now, this particular paper, again, we're jumping back to the 1990s, caused a particular stir. I gave a lecture in Boston in 1995, at which I talked about our work on intrauterine temperature. And Elise Lieberman, an epidemiologist, seized on this, and she did this very interesting paper looking at 16 and 57 nulliparous women who were afebrile on admission in labor. And if they didn't have an epidural, you can see the intrapartum fever, sepsis workup, and antibiotic treatment were all relatively low. But if the mother had an epidural, that dramatically increased. And this caused really quite a sensation at the time. This is a particularly exciting, or I found amusing, interesting paper, which I love to talk about. Now, this is about women having babies at the Tripler Army Medical Center in Hawaii. And they were obviously mainly Army personnel or married to Army personnel. And initially, they were only allowed to have epidurals for very few specific medical indications. And they actually lobbied Congress, and they got their Congress to pass a law which says they're entitled to the same treatment as civilians when it comes to pain relief in labor. They really did get this passed in Congress. And after October 1993, when they changed the law, you can see that in the subsequent year, there was a dramatic increase in the rate of women requesting epidurals. So perhaps the soldiers aren't quite as tough as it was thought that they might be. But what was striking was that temperature in labor recorded rose from 8% to 26%. And if we look at temperatures above 38, rose from 0.6 to 11%. So that's a 16-fold increase. And sure enough, they found about 1 degree rise every 8 hours on average. So this was a rather wonderful natural experiment showing the effect of introducing an epidural service on pyrexia in labor. Now, you may say, well, that's because it was in Hawaii, and that's a hot country. Perhaps there's something to do with being too hot. Perhaps that would apply in South Africa. Well, Scotland is not known as being a hot country. Here was a particularly interesting study where they looked at 480 consecutive term singletons who'd received epidural anesthesia, and they managed to recruit 480 matched controls who chose not to have an epidural. So they were matched for all the other major features. And what they found was predictable, you might say now, given the evidence, that the maternal pyrexia a neonatal pyrexia rate increased from 0.8% in the mother to 11%, in the neonate from 3% to 14%, and the sepsis workup again dramatically increased. So a lot of sepsis workup in clinical practice is due to the mother having an epidural. They actually said perhaps we shouldn't be so worried about pyrexia if it's due to the mother just having an epidural and there are no other signs of infection. Well, that remains to be seen. What about the possibility that this is all down to infection and prolonged labor? So this was an interesting study in 2014. They got 400 women. It was a randomized trial. Half of them were given antibiotics, half of them weren't, and there was essentially no difference in the rate of pyrexia. You notice these are really high. It's because they were monitoring these labors particularly carefully. If you think we don't see as much pyrexia as this, it's probably because you're not looking for it as carefully as these people were in this study. So we can say that antibiotics don't help. It's probably not primarily infection. So what can we conclude? Well, we know that labor duration is important, so it's how long you've had your epidural. That's very important. As soon as you have an epidural for a long period and you become pyrexial, you'll get an abnormal heart rate pattern in a high proportion, particularly tachycardia, and the babies then often end up in special care having antibiotics. Most intrapartum pyrexia is probably in modern practice due to epidurals, but the problem is we don't have a good way of checking that it's not chorioamnionitis. So at the moment, we have to assume that if the mother becomes pyrexial, she may well have chorioamnionitis. The Americans became very concerned about this. So back in 2016, they actually convened a study group at the National Institutes of Health to see whether if there was no other features of infection and it was just thought to be an epidural effect, did you actually have to give treatment for infection? And they said, okay, if it's just maternal fever alone with no other signs of infection, then you don't need to give antibiotics. But you had to know that the baby was not group B strep positive, so the mother had to be shown to be group negative, GBS negative. There had to be a normal fetal heart rate pattern. The mother had to have a normal white count, so that's less than 15,000, and there had to be no evidence of clinical infection. If all of those were reassuring, then you didn't need to give intrapartum antibiotic prophylaxis, or indeed antibiotics to the neonate. You could just monitor it. But of course, that can be difficult to establish, and particularly in the UK, we don't routinely at the moment screen, and that's another story. Now, finally, the last little bit of my talk, can we find a way to actually prevent this cause? So I'd like to bring to your attention this paper just published in March of this year, an excellent paper. The only mistake in it was that they underestimated how much warmer the baby is than the mother. They said it was 0.24 degrees, whereas in fact it's nearer 1 degree. But don't worry, they're publishing my letter to explain why they were wrong in this. Now, they concluded that epidural-related maternal fever is definitely a clinical phenomenon. It's not imaginary. At one time, people used to say, oh, I don't believe it, but I'm afraid you can't say it's fake news anymore. All neuraxial techniques, so however you produce pain relief by local anesthetics, whether it's a spinal, whether it's an epidural, it doesn't matter. They all are liable to induce maternal fever. And there are two main competing theories. One is that you've got inflammation with release of cytokines, and the other that there's disordered thermoregulation. And this is the one that at the moment that we're pursuing locally. Just a side issue, can we get rid of it with paracetamol? Well, 20 years ago, we published this paper showing that if you gave paracetamol, it didn't have a consistent effect on maternal temperature. Some went up, some went down. Just as many went up as went down, so that didn't help. And then there was this randomized trial. It's only a small trial, and you'll see why in a minute. Because actually, it didn't make any difference to the proportion of women becoming pyrexial. It was 1 in 4 in each group. So they stopped the trial because they said it was pointless. So giving paracetamol, unfortunately, has not been shown to have any beneficial effect on maternal fever in relation to epidurals or any other cause. So a medical student came along who'd been to Australia, and he said, well, why don't we try cooling the mothers down by putting these sort of like elongated wine coolers around their neck. They're called cobbers in Australia, apparently. And here he is. This is 20 years ago now. Gosh, how time flies. This is Vaibhav, and he's showing you how you could wear the neck cooler to cool down. So we were trying to cool the mothers down. But the initial one that we tried actually showed an increase in the fetal temperature. Rather, it went down initially and then it increased. And then with the fourth case, it got really bad because he kept putting on the neck coolers to try and cool this woman down, and the temperature went up and up. And you can see by the end here, the fetal temperature here, intrauterine temperature here, is above 40 degrees. The baby was passing meconium ++, and the baby had a tachycardia. So all of those three things you will be familiar with, the side effects of pyrexia and maternal shivering. The baby was not acidotic. So luckily, the baby delivered at this point. We were really worried about what was going on. And you can see here that there was thick meconium. The baby was floppy. We know that's a characteristic side effect of hyperpyrexia. No respiratory effort, required resuscitation. They obviously gave the baby antibiotics, but we knew it was actually a combination of the epidural and the neck warmers. And the amusing thing was he said to keep the baby warm, but the baby was actually rather too hot initially. But there you go. That's the usual thing that pediatricians do. So we thought, okay, what if what we're doing is actually causing the mother to feel even colder than she would with an epidural? Perhaps what we should be doing is warming her up. So that's when we introduced the idea of neck warmers. And here's a lady with a neck warmer. We did an initial randomized controlled trial. This is Tabitha with her neck warmers. And in women who didn't have the neck warmer, there was the expected average rise in temperature as the labor progressed, which we didn't see in the relatively small number of women who kept the collar on at least 50% of the time. About half the women took the warming collar off because they said it was a bit uncomfortable, not because it was too hot, but because it dug into their skin. What we did actually show, and I've in fact published, was that putting the neck warmer on significantly reduced the proportion of women who shivered. So that was another side benefit of the warming of the neck warmer. And we're getting near the end now. This is Christopher Mullington. I've already referred to his paper, and he set up a project with Professor Alison McGregor, in which I'm involved, to look at better designs for these neck warmers. As I've said, about half the women who were asked to wear the neck warmer found it rather uncomfortable. So our first priority was to design a neck warmer that was easier to wear. And here's our research fellow on sabbatical from China, who's devised a nice battery-driven device here. And these are the neck warmers, and you stick them onto the neck here. You can stick them on at the front. But interestingly, we found in experiments with volunteers, which we've now completed, that actually sticking them on the back of the neck seems to produce an equal, if slightly better effect. And it does seem to work. If you put the neck warmers on, it does seem to down-regulate the body temperature rather nicely. So what we're hoping is that we can down-regulate the temperature effectively if it's just due to the epidural, but that it won't have any effect if there's an infection. That, of course, remains to be seen. At the moment, we're completing the experiments on volunteers with the idea of later in the year moving on to actually studying women in labor using this new design of neck warmer. So, conclusions about temperature. If you have an epidural anesthesia, on average, the mother's temperature will go up, and therefore the baby's temperature, remembering it's 0.9 of a degree warmer, about 1 degree every 8 hours. If you have fever in labor, it makes everything worse. It makes heart rates worse. Your baby's more likely to pass meconium. The baby's likely to end up in special care, more likely to end up on antibiotics. So this is not a negligible problem. It's therefore clinically vital to monitor maternal temperature carefully. And in my opinion, this is not done often enough. It's not done carefully enough. Very often, if you see a fetal tachycardia, or the mother's been in labor for a little while and she has an epidural, if you take her temperature carefully, you will often find to your surprise that she's already pyrexial. So there we are. Thank you very much. I'll stop sharing my screen and see if there are any comments.
Thank you very much indeed, Professor Fulstier, for that most interesting presentation. We have a few questions.
Yeah.
The first one is Habib M. Habib from Nairobi. does it matter how you measure the temperature? Does it have to be a core temperature, a oral temperature, or an ear temperature with a laser? Which is the best way of measuring a woman's fever if one exists?
Very good question. The paper that we published 20 years ago, looking at the different sites, showed that the best correlate with the intrauterine temperature was actually the maternal oral temperature. And the difference is about 0.8 of a degree. So if the mother's temperature is 37, the intrauterine temperature will be 37.8. So this is normal, remember. You know, we're not used to thinking of temperatures that high. Any other site is worse. So tympanic membrane temperatures are particularly unreliable. They seem to greatly under-record intrauterine temperatures, and we've published that data. So it's important to be aware that if you have an oral temperature of 37.5, we're already talking about a baby's temperature of about 37.4, something like that. 37.3.
Right.
Sorry, it's 38.3. Yeah.
Next question. Given the effects of temperature caused by epidural analgesia anesthesia, has there been any increase or decrease in the incidence of epidurals administered in the Northwest Thames region?
No, we seem to be running particularly steadily at around about 60% for nullips and about 20% for Paris women. And it's been steady over the years. We don't see any, and we're not arguing that we shouldn't be using epidurals. What we're arguing is that we need to be more aware of the effect of epidurals if the woman has them for 3 or 4 hours or longer. Plus, we're looking for a way to control the temperature in a way that will prevent this happening in the future. So many of us will remember that going back 30 years, we used to use big doses of top-ups and women used to get hypotensive and it was a problem. Now this rarely happens because people are much more careful. They give smaller doses more slowly and so on. I think in the future, I mean, currently we would regard it as essential to monitor the woman's blood pressure if you give an epidural. In future, I think it'll become essential to monitor her temperature and probably to apply a neck warmer if the temperature starts to go up. That would be my prediction.
Yeah.
Right. Another question, the duration of epidural, is there a point at which one should not continue epidurals because of an unacceptable increase in epidural effects? In other words, how long can you run an epidural for?
Yeah, I think the answer is, depends on what the temperature is. I mean, if you're only giving an epidural for an hour or two, you probably don't need to be too worried about the maternal temperature. But I would say as soon as you get up to, say, 3 or 4 hours, certainly 4 hours, it should probably be a routine to measure the mother's temperature particularly carefully once you get to the 4 hours, because it's quite likely that that woman's temperature will be starting to go up. And if it is, you need to be aware of it. And the speed of it varies from some women to others. Other studies show that about 1 in 5 women seem to still be able to control their body temperature even with an epidural, but 4 out of 5 won't. So you need to sort out which ones are becoming pyrexial. So that the first reaction should be, if your woman's had an epidural for a few hours, check her temperature carefully, particularly if you see any meconium, particularly if you see a tachycardia. Fetal tachycardia.
Okay. Another question you have, Professor Steer, spinal versus epidural. Are these effects also noticeable in women that have spinals versus those that have epidurals, or is the effect less with spinals?
No, and this is what the latest paper shows, that it's no different, whatever. The reason for this, we think, is that the pain fibers, the ones that conduct pain sensations, are quite small, but so are the thermal ones, the ones that convey temperature. So if you block the pain fibers, you must automatically block the temperature sensors. And our hypothesis is that it's this lack of awareness of your body temperature that's causing the temperature control to go wrong. And of course, in labor, women generate a lot of heat. So that's why the heat is building up. They're not aware that they're hot because they're no longer feeling hot because of the effect of the epidural. So any degree of analgesia will automatically impair your thermal sensitivity in the same way. A spinal for a cesarean has minimal effect because it doesn't have long enough to make a difference.
Okay, that's interesting. Now, can you explain why, if a woman's temperature goes up then, or if a spinal causes the temperature go up, women shiver so much? Is that to increase her temperature? There's lots of shivering after a Caesar usually.
Yeah, Our theory is that it's because the woman's perception of temperature is disturbed and she feels cold even if she's not, and that's why she's shivering. And that's what gave us the idea that applying a warming collar might actually make her feel more comfortable and stop the shivering. What we are able to demonstrate in our trial of the 71 that we actually completed was that the portion of women shivering was substantially less. It was less than half as many women shivered. So that gave us a clue that it was working.
Okay. Right.
No,
Steve,
there's a question from Dr. Graham Birdsey where he's asking, are we suggesting that because of the danger, if there's a maternal temperature, that we should stop the epidural? He's not really sure if the woman would be happy with that.
how do you
suggest?
respond?
Do you try and get the temperature down, or what do you suggest?
Well, a common related question I get is, should women be told that if they have an epidural, if they have it long enough, they're quite possibly going to get a temperature and that will have these adverse effects? And the answer is, of course, they should be told that. It should automatically be listed as one of the side effects of epidurals when women are counseled about having an epidural in labor. So if they've been warned about it beforehand, they will know of this effect. And clearly, if the mother has a high temperature and she has an epidural, then you have to think about, do we allow that temperature? I mean, if the mother's temperature has gone up to 38.5, the baby's going to be at 39.5. We're in the risk of, heat stroke territory at that point. So if it was me, I wouldn't be keen on taking that risk with the baby personally. So it's not a question of whether she should continue the epidural. It's how you deal with that situation of the temperature when it occurs.
Okay, so if they're going to deliver very soon, that's fine. If they're not going to deliver very soon, then delivery should be contemplated.
Exactly.
Exactly.
And again, it talks to really, not maybe doing the epidural too early, because I mean, sometimes this is reflex of, induction of labor. Let's get the epidural up, and so maybe it is better to. I mean, do you think that's sensible in terms of timing of epidural?
There's another way of dealing with that, Stephen, and that is to put the epidural in, say, for an induction, so that the mother is comfortable when she's having an ARM, whatever, and then let it wear off. And you only restart it when she develops significant pain with her contractions, such as that it justified giving the top up. Just because you have an epidural doesn't mean it has to be topped up.
Absolutely. Yeah. So it's maybe he's talking about really just being sensible of how you top it up, and do the anaesthetists know about this stuff? Is this spoken quite extensively in aesthetic circles? I mean,
yes, I can remember for about 5 years in a row, I was invited. This was about 20 years ago. I was invited to speak every year at the Obstetric Anaesthetists Association annual meeting in the UK. And when I started, I would say, how many people are aware that epidurals cause the mother's temperature to go up? And it was very few to start with. And eventually, it dawned on everybody that this was a fact. And they stopped inviting me to give the lecture because people... and in fact, in the last couple of years, several of the big anesthetic meetings, the hot topic has been pyrexia secondary to epidurals.
Right.
It's very widely understood.
Yes, Professor Steer has spoken to the anaesthetist a couple of years ago. I remember you being invited to the anaesthetist to give a talk in Cape Town on that particular subject. And in fact, today, I spoke to my anaesthetist, Linda von Sale, and I said, we've got Phil Steer on tonight. And she says, let me show you a photograph. And there was a photograph of you and her. You won't remember her. But this was at one of those anesthetic. Now, she's my anaesthetist, and she showed me this. Anesthetic congress of you and her, the time that you spoke on this particular. So I don't know if they invite you back or not, but it's certainly something to be interested about. Well, Professor Steer, we've come unfortunately to the end of our bandwidth, and after 1 hour, we have to unfortunately say goodbye to you. It's been wonderful to have you this afternoon. Yes. Lots and lots of people have logged on, well over 100. Yes, well over 100. And your talk has been, as always, illuminating, and especially it has been clinically relevant. So it's a talk that we can all internalize, take home, and use in our day-to-day clinical application. So thank you very much indeed. And we hope, without any further ado, that we would have you for the fourth talk. Can I just ask you, are you going to the Royal College meeting in London?
No, I'm going to the World Congress of Perinatal Medicine in Milan this weekend.
Dear. So I won't see you in London next month.
Well, you might, but we'll see.
Okay. All the very best. Thanks once again on behalf of the Pelvic Floor Foundation. Steve, as always, is the boss.
Yeah,
You
thanks so
get the
much.
last word.
Yes, thanks so much, Professor Steer. It's always wonderful to have you, and we hope we can, invite you again quite soon. Just such a wonderful topic, and really, talking to Pete earlier, how theoretical research has certainly changed practice and highlighted a lot of very practical issues. So we thanks so much for that, and enjoy the day in London. And the evening.
Enjoy the evening and all the very best.
Thank you for inviting me, and keep taking the temperature.
Thank you, Professor Phil Steer.
Bye.
Thanks again, and goodbye, good night.
Bye.